In Section 8, Chapter 2, we'll look at steroid hormones. Let's start with adrenal steroids and remind ourselves that there are non-endocrine uses for adrenal steroids. We can double check once again inflammatory disorders. As far as endocrine uses of glucocorticoids, prednisone, dexamethasone, or if the mineralocorticoid, fludrocortisone. Notice we don't use aldosterone itself. They can be used simply for replacement therapy in Addison disease when you have hypoplastic adrenal or in any adrenal insufficiency states, such as issues where you had infection. Besides replacement therapy in Addison's disease, those adrenal steroids could be used in any adrenal insufficiency states, such as secondary to infection. Think of things such as tuberculosis that might have caused destruction through miliary spread of the adrenal cortex, or the Waterhouse-Friderichsen syndrome associated with severe case of meningitis, shock, trauma, where then they use as supplementation. Steroids, such as corticosteroids, are also used when babies are premature or when babies are from diabetic mothers. You remember when they have a lecithin to sphingomyelin ratio less than 2. And I think these should be kind of buzzwords for laboratory finding in hyaline membrane disease of a newborn, the lack of surfactant, or what we simply call respiratory distress syndrome. Otherwise, in adrenal hyperplasia, they could be used at high doses to cause feedback inhibition of ACTH. By the same way as we can use adrenal steroids themselves to supplement in case we have decrease or lack of them, we also have drugs that are adrenal steroid antagonists when we have excessive endogenous adrenal steroid responses. Think of spironolactone, which was blocking both aldosterone and androgen receptors. It could be used as an antiandrogenic, but it was also used as a potassium-sparing diuretic, and particularly would improve survival of people with CHF. But you may want to add to adrenal steroid antagonist the drug mifepristone, which blocks both glucocorticoid and progestin receptors. We mentioned mifepristone's use with misoprostol in order to promote abortions. And as far as synthesis inhibitors, the drug metarapone, which blocks 11-hydroxylase, it could be used to diagnose certain genetic deficiencies in the adrenal cortex that you review well in endocrine phys. Also, it's a common drug to use in Cushing's. And finally, the azoles such as ketoconazole, which are strong anti-androgen. If we look now at other steroids and we look at estrogens, estradiol is the major natural estrogen. As far as the type that we use in therapy, we use conjugated estrogens. Generally, they're isolated from pregnant mare's urine. And the most common semi-synthetic forms are ethinyl estradiol and mestranol. DES, diethylstilbestrol, is a non-steroidal estrogen, and its relevance is mainly that when it was used in high-risk pregnancies back in the 50s, it resulted, unfortunately, in an increased incidence in vaginal cancer in the daughters of the women taking this drug. Now, clinical uses of estrogens. Well, just like any of the hormones in situations of hypogonadism, here female hypogonadism, estrogens would be used for replacement. We know that another situation where estrogens are used for replacement is in what we call hormone replacement therapy, and this is postmenopause. Menopause is associated with a marked decrease of estrogens, and we worry that with a lack of estrogen, we certainly increase the risk of osteoporosis because of effect on calcium metabolism and homeostasis, and also increase the risk of cardiovascular incident in the postmenopausal woman. Estrogens are normally protective by increasing HDL and lowering LDL cholesterol. The only issue with hormone replacement therapy, the doses of estrogens used are fairly high, and estrogens being associated with hyperplasia of estrogen-dependent tissue, such as endometrium, ductal and lobular tissue of the breast, we know that they could increase the potential of developing neoplasias of those tissue. Estrogens are also used as part of oral contraceptive pill to participate in the feedback inhibition of gonadotropins. They're not used alone there, they're used with progestins. They've been used in dysmenorrhea, uterine bleeding, they've been used in acne. When they're used in prostate cancer, estrogens are used at very high doses in order to negatively feedback on the endocrine axis. As far as side effect of an estrogen alone, estrogens classically are associated with nausea, with breast tenderness, but most importantly to underline in your syllabus, with endometrial hyperplasia. This predisposes the lady to development of endometrial carcinoma later on in life. Otherwise, we know that estrogens and steroids in general are quite likely to increase the risk of gallstone formation, cholesterol stones that can cause cholestasis, biliary stones, and cholestatic jaundice. Estrogens have also effect on the vasculature. They tend to vasodilate. You may remember, for that matter, in pathology, how we see the high levels of estrogen in an alcoholic, resulting in spider angiomata, resulting in palmar erythema, all those ascribed to lack of detoxification of estrogens in alcoholics and ascribed to the vasodilation. Well, vasodilation in the CNS would result in migraine headaches. What is about the issue of blood coagulation? Here, you need to worry about the dose of estrogen. Estrogens have often been labeled as being terrible for thrombosis. The reality is this only occurs at very high dose of estrogen. And you know, a concern has often been oral contraception and potentially increasing your risk of blood clots and strokes or MI. The whole issue there is that really estrogens at the doses used normally don't increase thrombosis. More likely than not, if someone has a thrombotic event with estrogen, it's because they have a predisposing condition. And amongst predisposing conditions are simply age, you're more than 40, certainly smoking, which increases the risk of thromboembolic disorders by over 40-fold, and the previous history of thromboembolic disorders should always, of course, contraindicate the use of estrogens. How about the cancer risk to estrogen? Well, estrogens, through the hyperplastic effect, could increase the risk of endometrial cancers and potentially increase the risk of breast cancer. Certainly, if there are other risk factors present, such as a family history, a history of previous breast cancer, and so forth, or certain genetic makeup, then it would be recommended to try and avoid the estrogens. We talked about diethylstilbestrol and the issue of vaginal adenocarcinoma cancer in the offspring. Don't forget this for your pathology question. How about blocking estrogens? Well, we block estrogens often in cancer type of situation, and various drugs should come to mind. The first one in your syllabus is the compound anastrozole. Anastrozole is an aromatase inhibitor. Aromatase is an enzyme found very highly in adipose tissue and which is responsible for aromatizing androgens. When you aromatize an androgen, you end up with an estrogen. If you decrease aromatase activity, you decrease synthesis of estrogen, as you wish to do in estrogen-dependent breast cancers. Estrogen-dependent breast cancers tend to occur postmenopausally. Other estrogen antagonists may do it partially, and this is the case for clomiphene. Clomiphene is not used for cancer. It's a fertility pill. Essentially, if you want to have 20 kids at once, take clomiphene. Its mode of action is to decrease feedback inhibition and cause a big increase in LH, the LH surge, causing ovulation and pregnancy. Its adverse effect is seriously the issue of multiple births. When on TV you hear about a pregnant lady giving birth to 6, 7, 8 babies, generally it's because she has been taking clomiphene as a fertility pill. Selective estrogen receptor modulators include the very important drug tamoxifen. Out of this entire page in your syllabus, definitely mark clomiphene as a fertility pill and underline well the drug tamoxifen. Tamoxifen is often board tested. Tamoxifen has variable actions depending on the target tissue. This is because tamoxifen is the classic partial agonist of a receptor. In tissues where there is little estrogens around, it will behave as an agonist and stimulate, for instance, bone mineralization. This is why it would be good in osteoporosis. But in a tissue such as breast cancer, which has tremendous amount of estrogen and estrogen-like substances promoting its growth, the partial agonist will behave as a blocker. In the endometrium, it tends to work as an agonist also. Now, as a result of the agonist effect in the endometrium, there is always a possible increased risk of endometrial cancer when postmenopausal breast cancer females use tamoxifen. But the benefits of using tamoxifen in estrogen-dependent breast neoplasias are such that, of course, the risk will be incurred, since it can be used even for prophylaxis in high-risk patients. When you think of it in management of cancers, hormonal treatment are much better tolerated than any of the anti-neoplastic medications. With the observation that partial agonists can prevent osteoporosis, well, drug companies put on the market a drug very similar to tamoxifen called raloxifen, but the FDA approval and label for this drug is to be used in osteoporosis. It will behave, of course, as an agonist in bone and still as an antagonist, particularly in the breast. So, as a result, this partial agonist, when used in menopause, would not increase the cancer risk. Whereas contrast, using hormone replacement therapy increased the risk certainly of endometrial cancer, and although questionably, logically should also increase your risk of breast cancer. Partial agonists with ceiling effects should not do so. Let's look at the other sex steroids here, the progestin. Now, progesterone is the major natural progestin. Progesterone is normally not used as is. Rather, synthetic and semi-synthetic drugs are going to be prescribed, such as medroxyprogesterone, but also such as synthetic compound like desogestrel, norethindrone. A relevance of progesterone in endocrine phys is the fact that progesterone is not only a progestin, but is normally also androgenic and also anti-estrogenic. Well, an advantage of desogestrel is the fact that it's a synthetic progestin that only has progestational activity. It is devoid of androgenic and anti-estrogenic activities that are normally commonly found for other prescribed progestin. Let's imagine the relevance of this. Sometimes oral contraceptive pills, which are rich in progestin, are used to treat acne. And depending on the type of progestin in the oral contraceptive pill that would be used, well, you've got to be careful that the progestin would have no androgenic effect. Otherwise, the side effect would be to cause acne, to cause hirsutism. That's where desogestrel plays a role. It has no androgenic and no anti-estrogenic effects. Clinical uses, by far, those of contraception. So they're used in the pill, in the oral contraceptive pill, in combination with estrogens. Otherwise, you could imagine in hormone replacement therapy or with estrogens to decrease the risk of endometrial cancers. As far as side effects, progesterone overall in the body has one aim in mind: to allow gestation, like the name indicates. Obviously, if mom is pregnant, she has a great need to increase her LDL cholesterol to allow all these cell membranes of the fetus to have adequate cholesterol levels for fluid bilayers. She will also need a great deal of glycemia to allow the glucose to be used for production of ATP. Therefore, it's at no surprise that progestins used therapeutically will increase LDL and decrease HDL, increasing the risk of atherosclerosis. It is also at no surprise that they will cause glucose intolerance and should not be used in diabetic patients. Other classic effect of progestin: breakthrough bleeding. The issue of androgenic side effects of hirsutism and acne and anti-estrogen effect. Keep in mind that this would not be the case with the progestin known as desogestrel. Do we have a progestin antagonist? Well, we do. It's the famous drug mifepristone. Don't forget that mifepristone is also a glucocorticoid antagonist. That's why we mentioned it twice now in that endocrine section. As a progestin antagonist, it is used as an abortive agent with prostaglandins, particularly the drug misoprostol. Let's review a little bit of the pharmacology of oral contraception. Oral contraceptive pills are combinations of estrogens and progestin. They're generally in varied dose with mono, bi, triphasic variants depending on the levels of progestin to try and minimize side effects of the estrogen. The whole idea is to suppress the mid-cycle LH surge to suppress ovulation. Now, the side effect of the estrogens are classic breast tenderness, potential headache from vasodilation, the bloating and nausea that women often complain of when they take oral contraception. Progestin from their side are resulting in weight gain, potentially hirsutism and acne. Remember, that would be true of norethindrone, but not desogestrel. And also the issue of lipid profile imbalance, depression, tiredness. There are some significant drug interactions to oral contraception. If we induce cytochrome P450, we decrease contraceptive effectiveness. There's no better place to be tested on this but with anti-seizure medication. We know that phenytoin, carbamazepine are extremely teratogenic, and being inducers of P450, they decrease the efficacy of oral contraception. This is where, as we've already reviewed in the CNS section, you're more likely to be tested on this point. Now, certain antimicrobials might also interact either by induction, such as rifampin, or potentially by inhibition, such as macrolide or azoles. Are there benefits to oral contraception besides the fact of not being pregnant? Well, oral contraception decreases the risk of endometrial and ovarian cancer. This is the protective role of the progestins. Decreases dysmenorrhea, endometriosis, decreases the risk of PIDs by changing the pH of vaginal secretion, and decreases osteoporosis. That's due to the estrogen moiety. If there were to be a cancer to be board tested with oral contraception, at worst, oral contraceptive can increase the risk of developing a liver adenoma. This is a benign tumor, which does have an issue. It is heavily vascularized, and if it ruptures, would cause lots of intraperitoneal bleeding. Key point about that liver adenoma and oral contraception: when the oral contraceptive pill is stopped, the liver adenoma regresses. Let's finish our sex steroids looking at androgens. When we look at androgens, those are testosterone derivatives, particularly methyl or 17-alkyl derivatives of testosterone. These derivatives tend to have increased anabolic action, and classical drugs which are often used illicitly by athletes are oxandrolone and nandrolone. The normal therapeutic use is for anabolic actions for people who would need anabolism, an increase in body mass and an increase in particularly skeletal muscle mass, or otherwise in male hypogonadism. Or, you know, when you look at this section, what would you tell me would be a common genetic form of male hypogonadism? I would like a male with a bar body. I'm sure you're thinking Klinefelter syndrome. In Klinefelter syndrome, we have the famous karyotype of 47XXY. This would be a situation where testosterone derivatives would be relevant. What are side effects of androgen? Well, certainly if that's not what you wanted, you will get excessive masculinization. You know, a possible question with this is a lady who decides to do bodybuilding. Often the excessive masculinization could occur not only on herself, but what if she were to become pregnant? Then the use of androgen during pregnancy, which by the way is contraindicated, would result in virilization of the little baby. It would really mimic 21-alpha hydroxylase deficiency in the baby, causing literally pseudo-hermaphroditism in the little girl. Otherwise, androgens cause premature closure of epiphyses. That's why they should not be used in children. As steroids, they're eliminated through the bile. They can cause cholestatic jaundice, just like estrogens could. And if you wanted to have some CNS effects, you sure get them with androgens. Androgens typically are to be related with the aggressiveness of males. When you use androgens therapeutically or illicitly, you add on to your aggressive potential. Some people even refer to this as roid rage, roid for steroid. Finally, there is some issues with dependence to androgens. Some research shows that androgens have also effects on the reward pathways, and people can get hooked to androgens, particularly when they associate them with the positive reinforcement of exercise and body mass increase. Just as we saw previously for estrogens and progestin, the question is, do we have antagonists to androgen activity? What would we use them for? Well, we have two major antagonists on this page, flutamide and luprolide. Luprolide is a drug to mark with an asterisk on your exam, just like tamoxifen. This is often board tested. Let's start with luprolide. Luprolide is a GnRH analog. As a GnRH analog, it is used in depot form in advanced prostate cancer. The boards have always loved this point, so make sure you know it cold. Now, don't confuse this use of luprolide as a depot form with pulsatile administration of luprolide. If you give pulsatile doses of luprolide, you will actually stimulate the GnRH axis, increase FSH and LH, and actually be used in hypogonadal states. Besides luprolide for advanced prostate cancer, blocking androgen receptors can be achieved with flutamide. Certainly the side effect of blocking androgen are those to be expected from decreasing the levels of the hormone responsible for secondary male characteristics. Another form of an androgen antagonist is represented by the drug finasteride. Finasteride does not block androgen receptor, does not decrease synthesis of all androgens. Rather, finasteride is specific for the enzyme 5-alpha reductase. 5-alpha reductase normally reduces testosterone to dihydrotestosterone, and DHT is an active metabolite of the hormone. DHT is responsible for male pattern of hair loss and is also very much at the base of the prostate enlargement that we see in BPH. Well, blocking 5-alpha reductase has long been a major mode of approach in the management of BPH. You know that lately we've been using alpha-1 antagonists such as terazosin for BPH. As a result, a remarketing of finasteride has oriented the drug for its second effect, which is to promote hair growth and therefore to be used in male pattern baldness. Now, finasteride is often used as an ointment, and as an ointment, the male, the husband potentially, is going to put it on his skin. A big issue is that androgens, as we know, are teratogenic. So be careful if you put it on your skin. No doubt you could have some issues if you sleep next to your wife and she would actually get the finasteride preparation on her own skin. Now, for BPH, it's unlikely by then, unless you have the luck of being married with someone extremely young, it's unlikely that there would be an issue with pregnancy. Contrast, for male pattern baldness, there could be issues with the lady in bed getting exposed to finasteride, and if she were to be pregnant, actually getting teratogenicity from it. So be careful. And when it says here, caution teratogenicity, of course, we're not joking here and imagining teratogenicity in males. Last time I checked, males do not become pregnant.